Nice to see all our students coming up.
We are proud on the other side. Like,
Yeah, I think now it's live streaming has
Mhm.
started.
Coming up.
Yeah, it is done now.
we are
I mean,
we
you
are
can
proud on
start.
the other side. Like,
We can start.
Yeah, I think now it's live streaming
Yeah,
has started.
live, yes.
Thank you. Good evening, all. I am
Yeah, it is done now.
we are
I mean,
we
you
are
can
proud on
start.
the other side. Like,
We can start.
Yeah, I think now it's live streaming
Yeah,
has started.
live, yes.
thank you. Good evening, all. I am
Yeah, it is done now.
we are
I mean,
we
you
are
can
proud on
start.
the other side. Like,
We can start.
Yeah, I think now it's live streaming
Yeah,
has started.
live,
Some
yes.
voice issues there. I think some
Thank
voice.
you.
So
Dr.
repeating.
Mitesh, you may have to mute it. Yes, I think it's okay. Thank you, Dr. Mitesh. So, good evening, all. I'm Dr. Soumya Nagarajan, and I welcome you all for the second edition of Allergy India Dialogues through IAP Allergy and Applied Immunology chapter. So, before we start the session today, I would like to call upon Dr. Upin Narayan Reddy, the chairperson of the IAP Allergy and Applied Immunology chapter, to say a few words.
Good evening, everyone. So, respected past chairperson, Krishnamurthy sir and Neeraj Gupta sir. And this is a very important second episode of Allergy India Dialogue. This is for involving state chapters every month. It is very interesting to use local talent. So, today's topic is very interesting. There's a pediatric asthma, bridging evidence and clinical practice. Is a panel discussion. Main moderator is our past chairperson, Krishnamurthy sir. So, other panelists are Jijo sir and Gopika madam, Asha madam. I think very interesting, very interactive, more practical. I think it's very useful to all practicing pediatricians. Okay, all the best. Thank you.
Thank you, sir. Dr. Neeraj, would you want to address with few words?
Thank you, Dr. Soumya. I think very nice topic, very nice. I will say that selection of the speakers and the panelists, and especially we all have witnessed in past, you can say like 15, 20 years, that asthma management has really changed from therapeutics now to more towards diagnostic and immunotherapy and then preventive aspects. So this particular session is very important, and we are going to discuss different aspects of asthma. So my best wishes to the session. Thank you.
Thank you. Thank you, Dr. Neeraj, for your kind words. I would give a brief about today's topic. It is being conducted in association with Kerala Allergy and Applied Immunology chapter. And it's a panel discussion on pediatric asthma, bridging evidence and clinical practice, being moderated by Dr. Krishnamohan, our past chairperson of the IAP Allergy and Applied Immunology chapter. He's a consultant in pediatrics and pediatric allergy government health services department of Kerala. Our esteemed panelists are Dr. Jijo Joseph, who is also the president of the IAP Pediatric Allergy and Applied Immunology chapter of Kerala. He's the professor and head at the Believers Church Medical College. Dr. Gopika, ma'am, she's a senior consultant pediatrician, Anandpuri Hospitals and Research Institute. I just came to know now that ma'am is also the president of IAP Trivandrum. And I also, last but not the least, I think Dr. Asha Nazimuddin. She's a consultant pediatrician, Cosmopolitan Hospital. Krishnamohan sir, over to you to take us through this intricacies of pediatric asthma. Thank you so much.
Thank you. My screen is visible?
Yes. Yes.
Yeah.
Yes, sir.
Yes, slides.
Yeah. Now it's full screen, right?
Yes.
Okay. So at the outset, let me thank IAP Allergy and Applied Immunology chapter for this wonderful opportunity, especially the chairperson, respected Dr. Narayan Reddy sir, dear Soumya, who is the secretary of the chapter, Dr. Mitesh, and all EBs and OBs of the chapter. So thank you so much for giving this opportunity, as well as a very interesting topic and very useful topic for clinical practice. So in the next 30 to 40 minutes, we will be discussing on pediatric asthma, bridging evidence and clinical practice. So we have three brilliant panelists. or Dr. Jijo Joseph John from Kottayam, Dr. Gopika Shekhar from Trivandrum, and Dr. Asha also from Trivandrum. So to start with, we all know the GINA guidelines has been devised like it is like three different age groups. It's often discussed in three different age group: less than 5 years, 6 to 11 years, and 12 years, and the further adults. So we also will be discussing it like that only. So to start with, under 5 asthma, we know this is a really confusing domain. So from time immemorial, even GINA has been telling we have to approach the under 5 asthma on a probability-based approach. But in the year 2025, they have given some very important changes in the under 5s, both in the diagnostic clinical criteria as well as in the management. So, Dr. Jijo, what are the key clinical criteria recommended by the GINA 2025 to confidently diagnose asthma in this age group, given the diagnostic challenges in this particular age group? Over to you, Jijo.
Thank you, Kev. Thank you, Krishnan. Uh, like you rightly said, this has always been an age of contention when we had asthma because more than 50% of children under 6 years have at least one wheezing episode. One third of the wheezers transition to definitive asthma, and this is the most number of patients who come to the ED and OPD are going to be in this age group. Earlier, we used to call them viral-induced wheezer, happy wheezers, too young for asthma, maybe a transient wheezer. So all these labels were there. When we talk about GINA, we should also remember the other two guidelines which are also there, which is going to be the ERS one, BTS and NICE and SIGN guidelines also. The ERS one still focuses on recurrent preschool wheezing. They are very cautious regarding the nomenclature. And the BTS one is requires a little bit more objective confirmation with more focus on pheno, eosinophils, and also cost effectiveness. While GINA has become more proactive, the clinical diagnosis or labeling has become very important so that we can start anti-inflammatory use earlier. Our earlier retrospective phenotypes like late onset, transient, early, persistent, high risk asthma, all of those things are prospective ones which become a little difficult for a clinician to diagnose what is going to be the wheeze. The first important point at this point from the GINA is if you have all these three criteria, classical criteria, you can label a child under 5 as asthma. You need not wait till 5 years to call them an asthmatic. The first point is a recurrent acute wheezing episode or at least one acute wheezing episode with asthma-like symptoms in between episode. What do they mean by acute wheezing is wheezing on expiration, accessory muscle, difficult breathing, fast breathing, lasting for more than 24 hours can be called as a acute wheezing. Asthma-like symptoms will be a dry cough or wheeze after running or can be another way of talking about exercise-induced bronchoconstriction under 5, laughing or crying, which will be an emotional trigger, or even during sleep. This will be called as interval symptoms. That will be a first point. Now, second point becomes of utmost importance because in this age group, your likelihood of another diagnosis, alternative diagnosis is very high because you don't have many objective ways to diagnose asthma. So you should always be careful, especially in a child under 1 year. Your red flag signs should always be thought about. Whenever you have a red flag sign, you should consider other alternative diagnosis also. Then finally comes your timely response to your medication. What do you mean by timely responses? If a child gets better after giving SABA, salbutamol, say two puffs of salbutamol, the child gets better within minutes of an acute wheezing episode, or after nebulization, he is much better. Or even a severe episode, a few nebulizations, and prednisone is given, the child gets much better. We will term it as an acute episode. A response to your inhaled corticosteroid, response to your asthma medication. The next one is going to be a short-term response to SABA at home. And the final one is going to be a reduced frequency or severity of acute wheezing in between episodes once you're given a trial. So it can be a response to an OCS or SABA or a short-term response to SABA, or finally, if you're planning to give a trial of the treatment, the patient gets better, the symptoms are much more lower on ICS. The important point which we talked about earlier are on the right side of the slide. These are all the differential diagnoses which you will have to think about whenever you have a child with a recurrent respiratory problem. You consider the structural causes can present as your wheezing stridor, can be a tracheomalacia, vascular ring. Your infective causes, you should always remember if there is an elder sibling who attends school, it can only be a recurrent viral upper respiratory infection. But in many of these children, viral upper respiratory infections are the triggers. So that in itself can trigger an acute episode. Tuberculosis, wet cough, bronchitis, and in Kerala, we will think about PCD more than your cystic fibrosis. But there are other areas where we'll think about cystic fibrosis more. And all the classical ones will have their classical clinical features correlating. So even when you think about asthma, once you start a treatment, if the patient is not better after a trial with proper technique adherence, you will always revisit your alternative diagnosis to confirm your theory.
Okay, thank you so much, Jijo, for that wonderful points. So you have made the concept so abundantly clear, the three diagnostic criteria and why they are important. Especially the second one is very, very important. Asthma in this age group is almost a diagnosis of exclusion. So you have to think about the alternative causes, especially when the child is young. Now coming to Dr. Gopika madam. So we have diagnosed or we have made a classification whether it is an under 5 asthma or not. Now comes the next very important confusion or dilemma, especially in this age group when we advise them to start a corticosteroid or inhale corticosteroid. They will be really, the parents will be very tense because they already will be having the steroid stigma. So they will ask steroids in this young age. If we miss to start steroids, they may come back in the ER with acute exacerbations. So at this stage, how do you decide when to start the daily controller treatment in a child under 5? And how often should this treatment be reassessed for stepping up, stepping down, or discontinuation? Gopika ma'am.
Thank you, KM. So, when to start in inhalational corticosteroid in an under 5 asthma? As Joe has correctly said, during an acute care visit with asthma-like symptoms, wheezing confirmed by a healthcare worker, other diagnosis is unlikely. With a good clinical response to SABA, diagnosis of asthma can be confirmed. Once confirmed, Gina says a stepwise treatment approach is recommended based on symptom control, risk of future exacerbations, side effects, and response to treatment. Generally, treatment involves use of daily dose ICS, inhalational corticosteroid, to keep the asthma well controlled with as needed SABA reliever. So it should be Gina specially says it should be a personalized approach to asthma. You have to assess the symptom control, the modifiable risk factors, exacerbations, how they are using the inhaler technique, adherence, the child and parent preferences. Then you can adjust treat the modifiable risk factors and comorbidities, like in children it could be adenoid hypertrophy or allergic rhinitis. The non-pharmacological strategies can be made use of, how they are, you can adjust the asthma medications, everything. But everything Gina says depends upon the symptom control. So what is this symptom control? So once asthma is diagnosed, before starting treatment, you have to ask the symptom frequency for the child. That is, in the past 4 weeks, has the child had any of these symptoms and their frequency? Daytime symptoms, that is more than twice a week. Any activity limitation, as Jijo has said, for under 5 children, we can ask them as if it is when they are running about, when they are playing, if it is when they get tired easily. And if they are using any SABA syrup or reliever, that is the medication, bronchodilators, which is needed more than twice a week, any night awakening or night coughing due to asthma. So if all these are no, that means it is a well-controlled asthma. So if the one to two of these is an yes, it is partly controlled. And if all the 3 or 4 are yes, it is uncontrolled asthma. So Gina says, depending upon the stepwise management. Next slide, Kim. Next slide. So in the stepwise management, in the step 1, Gina says, infrequent acute wheezing episodes with no or minimal interval asthma symptoms, you can consider intermittent short course SABA or as needed, intermittent short course ICS or as needed a SABA reliever. But in step 2, when the asthma symptoms are not well controlled, that is, as I already said, daytime symptoms more than twice a week or any night awakening, or they are using SABA reliever, any 3 to 4 are present, when they are partly controlled or uncontrolled, you have to start daily low dose ICS. And this will be the most practical approach for as pediatricians when a child comes with a wheezing episode, and we have ruled out other techniques. It is better we start on them on daily low dose. inhalational corticosteroid. So next step, if it is not controlled, if the symptoms are not well controlled, and even with the low dose ICS, you can double the low dose inhalational corticosteroid. And if even then, if it is not controlled, if we have checked out the inhaler technique, adherence, as we have told, ruled out the modifiable risk factors, comorbidities have been addressed, and even then, if their compliance has been assessed, even then we have to go to step 4, that is double the low dose ICS, or continue refer to an asthma specialist for other ruling out other problems for this case. So in a case of asthma, if the symptoms are, the child is having any symptoms, which I have described in the second slide, for the past 4 weeks, if the asthma, we think it is uncontrolled, or the child is having any severe exacerbations in the past 1 year, requiring an ICU admission, then you have to definitely start. There is no other choice. You have to definitely start on a low dose inhalational corticosteroid for preschool children.
Okay, so Dr. Gobika has very beautifully described the different steps of management as per Dina in the under 5 age group, and as well as how to assess that. One point which has been added recently in the 2025 guidelines is that it is giving more importance to the lung function, because even in an under 5 asthma, lung function assessment is mentioned, meaning it tells us the importance of doing an FOT or an impulse oximetry, which can be done from the age group of 3 years plus. So just to summarize, in under 5 asthma, the treatment itself can sometimes be a treatment trial. So a trial of SABA may sometimes be required if there is infrequent or mild wheezing episodes, not requiring unscheduled medical care, and or mild intermittent asthma-like symptoms. Whereas a trial of daily ICS plus as needed SABA, it may be required if there are 1 or more acute wheezing episodes requiring acute care, oral corticosteroids, or hospital admission in the past year, and or asthma-like symptoms more than twice per week. So having discussed this much regarding the different steps as well as the assessment, we should also have a knowledge regarding the different doses of the drugs. As far as under 5 asthma is concerned, we need not have to study the doses of all the inhaled corticosteroids. Only budesonide and fluticasone is the most commonly used. We just have to remember what is low dose, what is medium dose, and what is high dose for each of these things. Another important point that we should always keep in mind is regarding formoterol. Formoterol, as of now, is not at all recommended for use in child less than 5 years. So it is not recommended. It is not supposed to be used routinely in this particular age group. Coming to the device, which device to be used? So you have decided the drug, then which device to be used? There is no doubt regarding that. We have to keep in mind always an MDI with a spacer, with or without a mask. Sometimes you need a mask if the child is very less. That is the best device that you can offer. It is the most versatile device. You just see this table where it is showing the proportion of drug deposition in the airway. As far as asthma is concerned, we need the drug to be deposited in the airway. So it is 10 to 15% in an MDA with spacer. And the oropharyngeal deposition is just the amount of medicine which is getting wasted. It is less than 10% if you are using an MDA with a spacer. If you are using an MDA without a spacer, the oropharyngeal deposition, as you can see, it is 40 to 60%. You see the bottom, the nebulizer, the much overused or hyped nebulizer, the proportion of drug deposition is very, very less. It is 1 to 5%, whereas the proportion of oropharyngeal deposition is extremely high. It is coming to around 50%. So selecting the right device also, as I already told, if any child who is less than 4 years, you need to use a mask. And any child who is more than 4 years, you have to use you need not use a mask, provided the child is able to do well with MDA with spacer. And the other devices like the dry powder inhalers, breath actuated inhalers, you can consider in any child who is 6 years above. But you just have to keep in mind, if anybody is asking you a question, which is the best device, you should answer, it is MDA with spacer. So coming to a case, because we already discussed the different steps, the different assessment methods, everything. So a real life scenario, here we have a case. This is a very smart 3-year-old Neeraj with recurrent episodes of cough, cold, and wheezing for the past 1 year. which is not often associated with fever. He is getting around 6 to 7 episodes per year, each lasting for about 2 weeks. He also coughs on running and laughing. He has some cough in between the acute episodes also, especially when he wakes up in the morning. He's having a history of atopic dermatitis in the past. There's a family history of allergic rhinitis in the mother, and grandmother uses inhalers. He usually gets better with nebulized salbutamol and budesonide. So how will you write a prescription for Neeraj? So, Dr. Asha.
Thank you, KM sir, and thank you, Allergy and Applied Immunology chapter, for this opportunity. This is, in fact, a real life scenario which every one of us has gone through. Now, I am curious why the patient's name is Neeraj. No offense, KM sir. Neeraj sir is amongst us.
Yeah,
So,
I have just told her he's a
yeah,
smart boy, smart boy.
yeah, yeah. But we need to help him with his asthma.
Yeah.
So this is a 3-year-old child, and as was mentioned by Jijo sir, he fits into our key clinical criteria. That is, he has recurrent symptoms of wheeze. He has shown a clinical response to SABA. We have practically ruled out all the alternative causes, alternative diagnosis. Plus, if you see, there are interval symptoms. That is, he is symptomatic in between viral infections. He has both infectious and non-infectious triggers for his symptoms. And there is family history of allergic rhinitis and a doubtful asthma. So we have no doubt this child has got asthma and he needs to be put on a trial of therapy. So a 3-year-old child, what would be the mode of administration? It would definitely be an MDI with a spacer and mask. So we would put him to initially a step 2 management, which would include MDI budesonide. We would start him with a low dose, which is 100 microgram, 1 puff twice daily with a spacer and a mask. For a period of 3 months, we would put him on a trial. Along with that, this would be the controller, and the reliever would be an MDI salbutamol, 100 micrograms, 2 puffs as required during episodes for any episode of cough, breathlessness, or wheeze. And how many can you give? We can give a maximum of 12 puffs of salbutamol in a day. So once this patient is started, you on inhalers, you need to spend time with the parents explaining about the use of it, explaining about the question. First question will be about the side effects of steroids. You need to tell them that this direct deposition into the lungs is not going to give you side effects, and the dose that we are using is very minuscule. So you spend time with the patient, and the patient goes home on inhalers. I would call him after 2 weeks just to see things are going well. I would like to check his MDI technique and spacer, and also with the check with the compliance is good. Meanwhile, we would also have to advise this child to get periodic annual flu vaccines as well as pneumococcal vaccines if he has not received that, and along with other routine immunizations. Most important thing to be sent along with the patient is an asthma symptom diary to monitor our treatment, whether it is working in the right direction or not, plus an asthma action plan guiding the parent what to do during an exacerbation of symptoms.
Okay, thank you so much, Asha, for detailing it very well. So, as she correctly said, writing a prescription for asthma is not just writing the name of the drugs. So, you have to write the diagnosis, you have to write the name of the drugs, the name of the device, how it should be given, how many times it should be given, and you should also give an asthma action plan, as well as you have to give something called as the asthma symptom diary to monitor how well he is responding. And most important, you have to tell him to review in 2 weeks. And if he's starting it for the first time, at every visit, you have to make sure that he is using the device properly. Along with that, you have to advise them regarding the vaccinations. All those things are very, very important. So thank you, Dr. Asha. Now coming to the next age group, 6 to 11 years, which is almost a comfort zone for pediatricians. But here, Gina has made it a little bit more confusing. So here also there are different steps. So Dr. Gopika, in this particular age group, that is 6 to 11 years, when will you consider step 1 and 2? And we see that for the last few years, there is no standalone SABA in this age group, even in the step 1. Why is it so? Gopika, madam?
So in 6 to 11 years, Gina has Gina says that if the patient has infrequent asthma symptoms, that is asthma, the symptom is divided into, depending upon the symptom, in whether it is frequency or infrequent asthma symptoms, that is less than 2 days per week, we have to start on step 1. Here Gina says step 1 is low dose inhalational corticosteroid along with whenever SABA is taken. If the asthma symptoms are present for 3 to 5 days per week, we have to start with step 2. Step 2 includes a daily low dose inhalational corticosteroid plus as needed SABA. Daily, if the child is having daily daytime symptoms with night awakening once per week or more, you have to start on step 3. Step 3, there are different options, which I think we can discuss in detail later. And if the child is having daily daytime symptoms with the night awakening more than once with a low lung function, we have to start on step 4. So infrequent asthma symptoms less than twice a week, we have to start on step 1, that is low dose ICS taken whenever SABA is taken. That is the main change Gina has brought about in the 6 to 11 year age group. That is, you should never take SABA alone. SABA should always be along with a low dose inhalational corticosteroid. And in step 2, we have to stick on to daily low dose ICS whenever there is symptoms are more than twice a week or 3 to 5 days a week, but with less night symptoms. So the why the Gina has included the inhalational corticosteroids, because there have been trials showing that there have been studies like the TRACK study, the ASSIST study, which shows that whenever we use a steroid, the studies are with inhalational corticosteroid formoterol, but even with inhalational corticosteroid, when we are using it along with the SABA, there is a more than 2/3 reduction in the emergency visits, in the hospitalizations, and also their recurrence chances of acute exacerbation. So Gina has definitely said that we should never, and there is a chance that whenever we are prescribing a SABA reliever alone, these 6 to 11 years, they will stick on to the SABA, and using more than 3 canisters of SABA per year has a very high risk of tolerance to SABA. So we should always emphasize on the point that in a case of 6 to 11 years, there is no reliever alone therapy. It should always with a as needed inhalational corticosteroid along with the SABA in step 1, or a daily inhalational corticosteroid with a reliever.
Okay, so that is a very, very important point that she has just told. In this particular age group, that is beyond the age 5 years or 6 to 11 years, there is no standalone SABA. So our conventional, the blue inhaler, the comfort inhaler, it has officially retired. You need not have to think about the blue inhaler alone. Whenever you are giving salbutamol, you have to give the inhaled corticosteroid also. So she has told regarding the step 1 and step 2. Now, what are the different options at step 3? So unlike the other steps, there are multiple options in step 3 which you can choose. Dr. Jijo.
Yeah. So in step 3, what we're looking at is, when will we start step 3? Step 3 is going to be when you have more daytime symptoms on most days and at least one nighttime symptom in a week. That is when you're going to consider step 3. So when we look at, there are different options. One practical way of putting it is, suppose the patient is already on ICS and the patient has budesonide with them, and you're stepping up from step 2, all you have to do is double the dose of ICS. That means if the child is on budesonide, you make it budesonide 2 puff BD. So that is going to be 100 microgram, 2 puff BD will be your dosage. Now, suppose the patient is starting for the first time and the patient doesn't have any inhaler with them. We are asking them to buy for the first time. Over there, I will prefer a very low dose ICS formoterol as a MART therapy, because the patient has to buy only 1 MDI, which is going to be a combination of budesonide with formoterol, 100 microgram of budesonide, and formoterol, as we know, 6 microgram, which the patient will take as a regular controller at night as a single dose. And the same MDI will be used whenever the patient has exacerbation, maximum up to 8 puff in a day. That is going to be a very low dose for ICS formoterol. Now, if the same patient is coming to you and the patient has salbutamol with them, and you're stepping up from your ICS and you don't want to continue ICS, you will prefer to step up to ICS LABA, or the ICS is about to get over. Over there, you will prefer going to a controller therapy with ICS LABA. You can use both fluticasone and salmeterol, or your budesonide formoterol as a controller, one puff in the morning, one puff in the night, and your salbutamol as and when required as your reliever.
Okay, so he has made it very clear. So we have got multiple options at this stage. One very important introduction or in change which has occurred over the last 3 4 years is that in the 6 to 11-year-old age group, now there is MART. So even with a single inhaler, you can use it both for maintenance as well as reliever. So as Jijo has rightly told, it is very low dose MART at this age group in 6 to 11-year-old. So that was step 3. So coming to the next step, suppose the patient is not getting controlled even after trying the multiple options, or I mean, using the MART or the medium dose ICS, still the patient is not getting adequate control. What are the different options in step 4, Dr. Asha?
So basically, in step 4, what we are dealing with the child who has daily symptoms and nighttime symptoms more than once per week, and this child also has a low lung function test. So in that child, if the child was on a low dose ICS LABA, we would step him up to a medium dose ICS LABA. That is, if the child was on a 100 microgram budesonide plus formoterol twice daily, we make it up to either you take 2 puffs twice daily, or you change the inhaler to a 200 microgram twice daily. Or we can use a low dose ICS formoterol maintenance and reliever therapy, not the very low dose. You step that very low dose group into low dose ICS formoterol maintenance therapy, and you also refer the patient for expert advice. An add-on which has come in step 4 is the use of tiotropium in children, which is a long-acting muscarinic antagonist, which is approved for use in more than 6 years children. It is available as MDIs or DPIs in a dose of 9 to 18 micrograms used once daily, add-on to the ICS LABA combination. Gina has suggested it as an add-on therapy at step 4 and 5 in children more than 6 years. But we should also understand that it is associated with some common side effects like dry mouth, constipation, abdominal pain, vomiting, muscle spasm, sometimes running nose, sneezing, nasal bleed, some painful white patches in the mouth, tachycardia, itching, angioedema, etc.
Okay, so she has made it very clear regarding the different options in step 4 as well as regarding the LAMA tiotropium. So that is step 4. Even now, the patient is not getting control. You just see step 5. What is written there in step 5 is refer for phenotypic assessment. So what is this phenotypic assessment? So we should be knowing regarding phenotypic assessment, because we all know now asthma is not at all considered as a single disease. You just see this picture. We have 3 kids there. One is an obese adolescent. Second one is a toddler with viral V's. Third one is a 7-year-old with severe eczema and asthma. All 3 of them are having asthma. But when you treat them, the response to the therapy may be totally different. So even though the diagnosis is asthma, it is nowadays, it is considered as an umbrella term. So there are a lot of phenotypes and endotypes of asthma, and now this is the era of precision medicine. It is absolutely important that you should do an attempt to rightly say which type of asthma it is. So you just see these are the different types of asthma. Basically, we can classify them into Th2 asthma as well as non-Th2 asthma. So the Th2 asthma includes the conventional allergic asthma, the exercise-induced asthma, aspirin-exacerbated disease, etc. Whereas the other group, non-Th2, includes the obesity-associated, smoking-associated, and the late-onset asthma. So basically, there are a lot of differences, including the key cytokines involved in different types of asthma. Like in Th2, it is interleukin 4, 5, and 13, whereas in Th2 low or the non-Th2, it is interleukin 17, interferon gamma, and TNF alpha. The inflammatory cells are also different. More important is the response to the therapy. If it is a Th2 high asthma, it will be responding well to inhaled corticosteroid as well as the biologicals. Whereas if it is a non-Th2 asthma, there will be a poor or variable response to inhaled corticosteroids, and even biologicals are having only a limited role in that. So phenotyping requires the usage of what is known as the biomarkers. So as of now, the different major biomarkers that we are using as per GINA classification, GINA is one is FeNO, which is fractional exhaled nitric oxide, the level of the blood eosinophils, as well as total and specific IgA. There are some other emerging and novel biomarkers also, like the serum periostin, proteomics, etc. But now, as of now, it is mostly in the research stage. Now, a few words regarding biologicals, because when we discussed the step 5, we said the option at step 5 is biologicals. We should know there are different classes of biologicals which are recommended to be used in asthma, starting from the earliest one, which is omalizumab, which is an anti-IgE, mepolizumab, which is an anti-IL-5, dupilumab, which is anti-interleukin 4 receptor antagonist. Tezepelumab, the latest one, is a TSLP antagonist. So the age group which is licensed also is little bit different. Omalizumab, mepolizumab, and dupilumab can be used from the age of 6 years, whereas tezepelumab is used mostly in the adolescents after the age of 12 years. So if you want to get more idea, or this is a very, very interesting article which by Dr. Professor Andrew Bush, you can just scan this QR code and you will get this article. It is freely available. But you should always remember this sentence. I took this sentence from the GINA guideline only. It has clearly mentioned, even though there are regulatory approvals, GINA recommends biologic therapy for asthma only if the asthma is severe and only if the existing treatment has been optimized. Or in simple terms, biologicals are the class of drugs which should not be misused. It should be used only after a proper evaluation and a proper optimum treatment. Now coming to the next case. So we have discussed this 6 to 11 year treatment. So coming to a real life scenario. Here we have got a very smart girl, Sinchana. She is 7-year-old. She is having history of frequent cough, nighttime awakening almost 3 times a week, early morning breathing difficulty many times a month since 1 year. Most of the episodes are febrile. She visits the GP clinic, nebulize with salbutamol several times a week. Now nebulization at home, salbutamol nebulizer many times in a week, school absenteeism once or twice in a week. So how do you position this child, and you please write a prescription? So as you can see in this picture, this is a typical Indian patient which usually occurs in our own scenario, a patient who is having asthma, who is very fond of nebulization, nebulization at home, nebulization at hospital, nebulization even at the neighbor's place. Every time he is getting nebulization with salbutamol alone, unfortunately, there is no controller. So this is a common scenario which occurs in our setup. So Dr. Gopika ma'am, so can you please write a prescription for Sinchana?
So the prescription, as Kim correctly told, this child, this is the frequent scenario we are usually getting. They will be more comfortable with a salbutamol nebulization than taking an inhalational corticosteroid. So we have to counsel the parent and say that nebulization and salbutamol will place her at a more tolerant situation. That is, she will not be responding to in our treatment, either inhalational nebulized steroids, and she will land up in ICUs, and she will be having more severe exacerbations if she continue like this. And we should make them confirm them that they should use an inhalational device. And although the symptoms fall into category 4, that is step 4, she has more daytime symptoms daily, night symptoms more than once a week. Even if there is no facility for doing a lung function, I think we'll put her in step 4. And for a 7-year-old, it would be best with an MDA with a valve spacer. There is no need for a mask. So since she's starting for the first time, as Dijo has correctly told, we'll go for a low dose MART therapy. MART means maintenance and reliever therapy. Here the low dose means budesonide 100 microgram plus formoterol 6 microgram, 1 puff BD, that is 12th hourly. And once you start a treatment, it is you should tell them early itself that you should not stop in between. You should continue for 3 months. So in the first prescription itself, we will have to write it as it is a budesonide 100 microgram plus formoterol 6 microgram, 1 puff 12th hourly for 3 months. that they should get dilated. They cannot taper it earlier, but they should continue for 3 months. After that, we will decide. And one another option is medium dose inhalational corticosteroid plus LABA. Here the LABA is not formoterol. You can use salmeterol. Then, but the inhalational corticosteroid dose should be a little high. Will come to 200 microgram of budesonide plus or fluticasone plus a long-acting beta-2 agonist other than formoterol. That is salmeterol is the one we usually commonly use in Kerala. Along with that, if it is a low dose mark, she need not buy another reliever. The reliever itself can be the controller. That is budesonide plus formoterol inhaler can be in her asthma action plan. We can use is that if she gets a acute attack at home, or if she gets an asthma symptom like night cough or anything on the step 4 treatment, the preferred reliever is also the same marked. That is budesonide plus formoterol inhaler, 1 puff as needed. But as we discussed earlier, it should not be more than 12 puffs per day. Then along with that, we should also counsel them to avoid triggers, allergen exposures, maintain the symptom record, regularly the asthma symptoms, the cough, wheeze, breathlessness, chest tightness, anything what are the triggers which constitute which make her the symptom precipitate. Daily PFR monitoring, that is a very easy method. They can get a breathometer and they have to record their maximum PFR best in them, and they should do a daily PFR monitoring. And once she is on step 4 treatment, because she is having inhalation, we have to ask them to get back after 2 weeks so that we can reassess her inhalation technique and adherence also.
Okay. So thank you so much, Monam, for that wonderful prescription. So one important point ma'am told is that just like we did for the under 5, here also we have to maintain an asthma diary. For your information, you just should know that IAP Allergy and Applied Immunology chapter, we have released a digital asthma diary app around 3 years back. It is available in Play Store. It's a very useful app so that you can give it to your own patients and they can record their daily symptoms in the phone itself. And once they come back to you, you can just take and by a click, you will get all details for 1 month. So coming to the next age group, adolescents and adults. So beyond 12 years. So we know that from 2023 onwards, Gina is considering the 12 years plus and adults under 2. We can see there are 2 panels like this step. So 1 track and 2nd track, track 1 and track 2. So Dr. Jijo, why is Gina considering this track 1 and track 2? Among these 2 tracks, which is the preferred track?
Okay. Thank you. So the question being is why 2 tracks? Why 2 tracks is basically earlier what we was taught was only the track 2. Then as and more evidence has come in after the smart therapy evidence which had come in, what has been clearly known is these children who are in step 1 or step 2, even though they will have mild intermittent symptoms, they can always have a severe attack. And as we rightly spoke earlier, there is no more blue inhaler alone, like Kim told earlier, blue inhaler has been retired. So always it has to be an AIR therapy or an anti-inflammatory reliever therapy. When we ask the patient to be on ICS plus SABA over a long term, the many times they will tend to default it. So default chances are extremely high. So in track 1, what is preferred is as long as the patient has up to 4 to 5 days symptoms also, and no night symptoms, the patient can use as and when required ICS formoterol. For a 12-year-old child, the dosage is going to be reduced at 200 with formoterol of 6 microgram. They can use up to 12 puffs whenever they have symptoms in 24 hours. So that is as good as taking low dose ICS and using SABA as and when required. That is what the data have shown. So the preferred therapy is going to be in a 12-year-old, and even any of us, if we have asthma, is going to be to start off with budesonide and formoterol combination rather than ICS plus SABA as a reliever.
Okay, so the most important take-home message that Dr. Jijo is telling is that track 1 is the preferred track, and the basis of making track 1 and track 2 is based upon the reliever which is used. So you are supposed to use, if as far as possible, you use the track 1. So Gopika ma'am, what are the different steps and treatment options in track 1?
So as everyone has discovered, track 1 it is an anti-inflammatory reliever therapy. That is the difference between track 1 and track 2. So it is not a bronchodilator alone. The reliever is an AIR, anti-inflammatory reliever. Here they have combined the steps 1 and 2 together, and they are saying we use as and when required. When the symptoms are less than 4 to 5 days a week, you can use low dose ICS formoterol. And the reliever is also a low dose ICS formoterol. Low dose marked means budesonide. For adolescents, it is 200 microgram, 1 puff daily. When in step 1, 2 and 3, you can take the symptoms are most days or waking with asthma once a week. The night symptoms are there. You have to go for a low dose maintenance ICS formoterol. That is 200 microgram budesonide with the 1 puff or 100 microgram 1 puff BD. If it is step 4, that is a medium dose maintenance ICS formoterol, daily symptoms with night awakening and low lung function. In the step 4, as we have discussed in the 6 to 11 age group, here the budesonide in adults, it comes to 200 to 400 and high dose is more than 800. Sorry, the low dose is 200 to 400 in adolescents, 400 to 800 medium dose, and more than 800 is high dose in adolescents. And in the 6 to 11 years, the low dose is 100 to 200, medium dose is 200 to 400, and high dose is more than 400. So even in the step 4, they are saying you can consider a short course of oral corticosteroids if the patient is having very severe uncontrolled asthma. And as discussed earlier, when we are gone to step 5, we can add on LAMA and we have to think about the phenotypic assessment and think about the biologicals. So this treatment track 1, they say, as said earlier, anti-inflammatory reliever therapy. It reduces the risk of severe exacerbations, ER visits, hospitalization. It is very simple and ensures adherence from patients. That is, they have only one inhaler to use.
Okay, thank you, Gopinga ma'am, for making it very simple. So the doses of this low dose, medium dose and all, there is no need to buy heart. You just can take a printout and keep it on your table for your reference. So another important frequently asked doubt, what is the maximum dose of MART per day? So you are advising MART. So you have started on MART. What is the maximum dose? How many times, how many total number of puffs you can use per day? So what they have told is based upon the maximum dose of formoterol which is recommended. That is, it comes to around 72 microgram of formoterol. So it is 12 inhalation of inhaled corticosteroid formoterol PMDA and in more than 8 years, and in other children it is 8 inhalations per day. And it is same for the beclomethasone formoterol also. So now coming to another important question. Once you start the patient on this inhaled corticosteroid, even now the patients and parents will be having a stigma, the steroid fear will be there. So they will always be anxious. When are you going to step down this? When are you going to stop this? So Dr. Asha, when to consider the stepping down and how will you go ahead? How will you step down?
As Kame sir mentioned, the first question a child and the parents come back to us after the symptoms are getting controlled. The first question to us is, Doctor, when can we stop the inhaler? So what are the points when you plan to? We have called the patient. Once we have started the inhaler, we have called the patient in 1 to 2 weeks time. We have assessed the compliance. We have checked the drug administration technique. And we call the patient again after 4 weeks and we see how the symptom control is. We ask the child to bring his or her symptom diary and we see how much was the daytime symptoms, was there any nighttime symptoms, what was the quality of life of the child. And now if the child has had proper symptom control over the past 4 weeks, then we again have to assess what is the future risk for poor asthma outcomes. So what are the factors that you need to consider when you assess the risk for poor asthma outcomes? One is uncontrolled symptoms. A child whom you have started on inhaler has not had symptoms, proper control of symptoms. That is, he still has nighttime awakenings or still has exercise triggered symptoms. That child is not ready for stepping down of your inhaler. The child who has had severe exacerbation in the past 1 year. You see the child has landed up in the ICU once or twice the last year. No hurry in stepping down inhaled corticosteroids in that child. Usually, if the season is, child's flare-up season, say prior to Diwali, prior to Holi, when you are expecting a flare-up of the respiratory symptoms in general, please do not step down the MDIs. Again, if you have an exposure or an exposure to trigger is expected, say like festivals coming up, the child has a sports event, the child has an exam coming up, we do not consider stepping down of the inhalers. Or if you know that the child from your symptom diary and from clinical assessment, you have a doubt on the compliance to the MDI therapy, those children also we need to reconsider our thoughts on stepping down the treatment. Now, if a child who has been properly controlled on symptoms and you don't expect an immediate risk of poor asthma outcomes, you don't have any of those flare-up seasons, you don't have any trigger coming up, in such a child, we can consider stepping down of treatment. And how do you step down? While using, if the child was on ICS alone, that is a child who was using budesonide alone in medium to high doses, we can consider a 50% reduction at each 3-month interval. That is, if your child was on 200 micrograms of budesonide twice daily, you make it to 100 micrograms twice daily, and you give that dose for another 3 months. And now, if your child is under control for the next 3 months, you reduce it to a further 50%. So that will become 100 micrograms once daily. So you switch it to a once daily treatment, and then you come off the inhalers in such a child. When your child is on an ICS plus LABA, again, you try to reduce the dose by 50%. That is, if your child was on a formoterol budesonide 200 twice daily, you bring it down to 100 twice daily. Again, you bring over 3 months. Then again, you bring it down to 100 once daily, and you come and taper off the MDIs. So basically, this is a flowchart describing the same. Your child was an ICS LABA, that is a budesonide, formoterol, 100 micrograms, 1 puff BD, you make it 1 puff OD, then you make it 1 puff BD, along with the, whenever there is a respiratory symptom or a viral URA, use it for 1 to 2 weeks, and then you come down to, if at all, there is a symptom, SOS SABA. If the child was on a medium dose ICS, that is 100 microgram twice daily, 2 puffs twice daily, you make it 100 microgram, 1 puff twice daily, you again come down to 1 puff once daily, then again step down to whenever there is a viral respiratory infection, you give 100 microgram twice daily for that 1 to 2 weeks, along with the reliever SOS SABA. If you use a very low dose ICS formoterol, that is a 1 puff night once daily that you're using, you step it down to 1 puff SOS along with a reliever, budesonide or formoterol SOS. So the total duration of treatment is on an average from 6 months to 1 year, depending on how your patient responds and depending on other factors that you consider when you step down the treatment.
Okay, thank you, Dr. Asha, for making the concept very, very clear. You have made it very simple also. Thank you so much. Now comes the million-dollar question. The mother will ask you, when are you going to stop the treatment? They are worried about the steroid things, and when will you stop the treatment? So you have to remember, if there is a very good control means mild symptoms or very infrequent symptoms, no activity limitation, no sleep disturbance for at least 6 to 12 months, and if there are no risk factors for exacerbation, you can plan to stop the daily controller regimen. But you have to remember, the trigger avoidance should continue, and you have to give a written home management plan for the acute episodes, which will be usually your step 1 regime. So it will be either, if it is an under 5 child, it will be usage of the salbutamol alone, or in the 6 to 11 years, it will be usage of salbutamol along with inhaled corticosteroid whenever it is used. You have to follow up for at least 1 year for every 2 to 3 months. The most important point is that you have to tell them asthma is a chronic disease. This is a disease with remissions and relapses. So stopping the inhaler doesn't mean that you have completely cured the disease. This is not like a surgery. It is not the end of the treatment. Anytime the child is getting exacerbation or anytime the child is becoming symptomatic, you have to restart the management. And restarting the inhaler therapy doesn't mean that you have failed in your management. That is how, as far as asthma is concerned, a very good control is as good as a cure. So that is a very, very important point you have to convey with your parents. So coming to another question, Dr. Jijo, this is a recent concept which has come into the GINA for the last 4 or 5 years. Previously, it was not at all mentioned, and this was a controversial topic for years together. I still remember during the Respicons and all, this was a debate topic, whether to use allergen immunotherapy in asthma or not. Jijo.
Yeah. So at this point, we have slowly have evidence creeping in, and with more and more evidence coming in, we have evidence to say there is a role for immunotherapy when it comes to asthma. Your subcutaneous immunotherapy, it may reduce your ICS requirement and improve your quality of life and lung function. At this point, it's a low strength evidence, but still the evidence is coming in. But definitely, there's a moderate strength evidence to reduce the ICS usage. You should always consider the benefit versus adverse effect, understand whether the patient is going to take the injection regularly, how long the patient is going to be adherent, choose the right patient. The most important point is this should be done only by practitioners who have specific training, they have resource for anaphylaxis, they know the treatment protocol which they are going to use, their standardized extracts are available, and all safety protocols are given. When it comes to slit with HDM, and especially the advent of your HTM sublingual tablets coming into the array, it is going to make a huge difference, especially in patients who are having persistent symptoms despite using ICS. And your FEV1 should be at least above 70%. So you shouldn't wait if you're considering slit for a patient to have an extremely poor lung function, because by that time you would have missed the bus. Those patients again should be considered as slit therapy after a shared decision making with the parent, considering all the benefits against cost and the risk. One of the other things is for ragweed season, where you will consider giving it prior to the season, provided your FEV1 is more than 80%.
Okay, so I would like to reiterate 2 points which Jijo has mentioned. One is regarding the control of asthma and immunotherapy. You are not supposed to use immunotherapy in a poorly controlled asthma. So first and foremost prerequisite before starting an immunotherapy in asthma is that it should be a well-controlled asthma, a FEV1 which should be more than 70%. Second is regarding which allergen the patient is sensitized to. So the best evidence is for house dust mite. So that is the reason why even Gina is advising house dust mite slit immunotherapy from the step 2 onwards in the other controller option. So that is regarding immunotherapy. Now coming to the last part. So we were discussing regarding the management options. So there are some preventive options also. Regarding immunizations for children with asthma. So, Gopinga ma'am, what are the different options or what are the specific advices you want to give your kids with asthma? Which optional extra vaccines should you give and all?
So, children with asthma should receive all the age-appropriate vaccines as any other child, but we can advise them for influenza vaccination, the new one. Every year there is an annual change in the influenza vaccine. We can advise at 6 months of age if the child is having episodes of bronchiolitis, which we think that the child has family history of asthma. The child can go in for developing asthma. We can say because flu viruses can trigger asthma flare-ups. So all children, if up to 9 years, they are saying if they are having moderate to severe asthma, they are recommended to take annual flu vaccine. But one thing we should say that it is not the influenza alone that causes flare-ups. There are other viruses also which can cause flare-ups. So, but a majority of the infections can be controlled, or which can precipitate asthma. H1 influenza vaccine can stop that one virus. So with that advice given, we can ask them to take up to 9 years. We advise 2 doses. And when first dose, we have to take, first time they are vaccinating, we have to give them 2 doses, 1 month apart. Then after that, annual 1 dose. If after 9 years, it is recommended that we have to give only annually 1 single dose every year. So before that, we have to take that, we have to say that many viruses are there, but only this flu vaccine will prevent the influenza virus, which can precipitate a severe asthma. Pneumococcal vaccination, although there are no special recommendations, if they have not been, now the national immunization schedule includes the pneumococcal vaccine also for all children. So if they have not come under that umbrella, it is better to take 1 pneumococcal vaccine, 1 shot for children about 2 years, so that they will get covered from getting pneumonia and prevent any other infection also. So that is not a special recommendation for asthma, but usually we advise this flu vaccination and pneumococcal if they have not been taken.
Okay, points well taken. So, Madam has conveyed very clearly, you have to take all the age-appropriate vaccines, especially influenza vaccination. Even the ACVIP is recommending to take a influenza vaccination for those kids who are having asthma. So, as Madam has told, you have to give 2 doses to start with and then annually. And it has to be, there is no confusion regarding the hemisphere of vaccines. Previously, there was some confusion regarding southern, northern, and all. But now what ACVP is telling is that you use the most recent strain of vaccine which is available, let it be northern hemisphere or southern hemisphere, whichever strain which is available more recently, you have to use that, and you have to give it in the pre-monsoon time, at least 2 to 4 weeks before the influenza season. So that ends the presentation. I think there are some other questions in the chat box also, and we can take, I request the panelists to take those questions. Dr. Jijo, can I stop sharing now and we can take?
I'm in the lid. I'm not sure if I'll be audible.
So I will take the
So the
question.
first question is the trial of ICS in
Trial of ICS.
this is budesonide 200 microgram BD or 100 microgram BD? I think when in step 1, the trial of ICS is 100 microgram
100
BD.
microgram BD, yeah.
We'll start with a low dose because it is for infrequent asthma symptom. We are giving a by infrequent viral wheezing. We are giving a trial only. So that will start with a low dose would be. Sir, Neeraj sir has asked, is there any recommendation against formoterol? Is there not enough evidence?
Yeah, it is regarding the lack of evidence regarding the safety in this particular age group. So probably in another few years, if the studies come, it can be advised in that age group also. But as of now, as Gina as well as other guidelines are not recommending to use the formoterol or the LABAs in this age group.
Next is there any use of fluticasone in India? We get plain fluticasone inhalers. We have under 5 years, we have put the doses of budesonide and fluticasone. I think that is why sir asked. I don't know any plain fluticasone in India. We get only combination with the salmeterol fluticasone.
I think Cipla had this fluticasone. I'm not using. I have used in my practice. I have used only budesonide, but I remember seeing fluticasone from Cipla. Jijo,
Sorry, I didn't hear the question.
fluticasone is available in under phase.
Standalone fluticasone. Plain fluticasone.
Alone fluticasone had come into the market.
Yeah,
right
it was there.
now it is mostly seen with patients who are coming from abroad and Middle East. They are the ones who have regular supply of Plixotide is what is usually they use over there. And the children who are coming from the UK are usually on beclomethasone as the first time. This is a change which we see patients who are coming.
Okay. You have been muted, Jijo. We lost your sound.
Next is can spirometric. Hello?
Yes, please go on.
Can spirometric guide for stopping of inhalation corticosteroid? Is there any cutoff for FEV1? Actually, now Gina says that when we call them back before stopping, we have to do a spirometry and see that is lung function should also be normal. Because even if the symptom control is there, then when we do a spirometry, we can see that it is FEV1 is not. They said FEV1 should be more than 80%. So there is a now the new guidelines say that the lung function should also be objectively normal to stop inhalational corticosteroid. KM, any addition?
No, you have said it right. Dr. Neeraj, you're still there or not? Neeraj ji, Mitesh ji.
Yes. Dr.
Yeah.
Neeraj is here.
It was
So
an
now-
excellent discussion, excellent session which happened, and I really enjoyed the discussion. And as you rightly mentioned, that regarding the formoterol. So this basically when we are talking about this combination of budesonide and formoterol, there are a few things which we need to be very careful. So first thing is that definitely uh, there is nothing against using this combination below 5 years, but right now the safety studies we need to have more, you can say, like evidence for that, and then we can recommend. But there is nothing against using it. So this is one. The second thing is about like when you are using, for an example, budesonide alone, and at that particular time, suppose if somebody who is having, like, let's say 100 microgram puff, and you need to give 400 in the morning and 400 in the evening, so there is no harm in using 4 puffs in the morning and 4 puffs in the evening. But that doesn't hold true for the combination. The combination, like for an example, budesonide and formoterol, then at that particular time, if you want to start, you can say like a 400 microgram in the morning and 400 in the evening, and if you are using a 100 microgram pump, then at that time the formoterol dose will be going 4 times. So that we need to be very careful, because whether it is 100, 200, 400, whatsoever, the formoterol dose is fixed. Each time, each pump, it is giving you 6 microgram. So that we need to be very careful that the toxicity of this formoterol, which might happen. So we need to be careful with that. So I think overall it is an excellent session, no doubt about that. And definitely now we are moving towards precision medicine, and there is more and more role of newer, I will say, function technique. One is oscillometry, which is now coming up. Then people are also trying to do now endotyping by using phenotyping and endotyping by using pheno, which is another thing, and using its management. And then obviously the other very important aspects, like when I think Dr. Asha was mentioning about the prescription. So one other thing about the prescription is about the preventive steps. So that preventive steps should also be added up. Like for an example, you need to avoid these things. That could be certain triggers. There could be certain, you can say, like if we know the allergens, then at that time that could be that also. So all these things, definitely comprehensive management plan is very much needed. It is not only the treatment, and ultimately patient needs your time. But excellent discussion, excellent session. Thank you, Dr. Kishwan. Thank you, Dr. Jijo. Thank you, Dr. Gopika, and thank you, Dr. Asha. I really enjoyed this session. Thank you for doing that.
Thank you so much. So I think there are no more questions. If there are no other comments from the other panelists, and
Yeah, so there are no more questions right now. So there is another important thing which is now going to come up. So we all are aware that we have started Allergy Bulletin, which was a monthly initiative which was started, I think, last year in March. So last year March was the first bulletin which came up, and then now the newer team once again want to, you can say, like I will say that continue that Allergy Bulletin thing, and they are now going to release, and they want to you can say, like, continue with this session. So I would like to invite Dr. Sanjukta ma'am. Dr. Sanjukta Day, please unmute yourself. And so she is the lady behind the Allergy Bulletin, and she is taking care of this Allergy Bulletin very well. Dr. Sanjukta?
Yes, Dr. Neeraj, thank you very much. If you, I would say that it's a huge teamwork, and thanks goes to all the team members of the allergy team. Dr. Neeraj Gupta, Dr. Soumya, Dr. Upinarayan Reddy, Dr. Mitesh Kakkar, and my editorial team for helping me with this. So this is going to be a quarterly bulletin, and it's a knowledge initiative, as you can see. So quarterly, so this one we called it the spring bulletin, spring edition between January and March 2026, and we are introducing the team to everyone around India, and we have messages from our team members, as especially, of course, our chairperson, Dr. Upinarayan Reddy, who has outlined what he wants to do and for the coming year, and Dr. Soumya, who the secretary's address, of course, and our plans along with the webinars and the activities she has planned for the chapter. And we are going to have a experts column, as well as a wrap up was of Dr. Neeraj Gupta has kindly made an extensive summary of all that was done in 2025, and all the things that we have achieved, which is a great deal, as you all know. Hence, we got the second prize in the IIP chapter. We had a very successful Paralelcon. All that is outlined. So the activities and how we can become members are also outlined in this allergy bulletin. And would request everyone present in this meeting and otherwise circulated widely amongst the group. Our books came out, and so we were going to have our expert column, case discussions, and also encourage all the members to send in their pictures and all the activities, allergy-related activities that they do throughout the next coming 3 months, so that for the next bulletin, we have the very comprehensive pictures and presentations of all our allergy team, which will be very good for understanding how we are forging forward. So I'd also expect you to contribute. I will reach out personally to you, and if you really want to say something, write something, please feel free to contact me or Dr. Neeraj Gupta or Soumya. And I hope you enjoy the bulletin and all that is written in there. We have also summarized the webinar here, and there is a patient information leaflet. Dr. Shoibal Moitra, as usual, has given us a very nice, comprehensive thing to read as well, updates on epitopes. So I think we are also running short of time, so I won't take too much of your time. It also outlines how you can become the EACI member along with the allergy member. So thanks to Dr. Neeraj Gupta, to everyone in my team to make this possible. And looking forward to more contributions from everyone for the next allergy bulletin, the summer edition.
Thank you so much, Dr. Sanjukta ma'am. And now I would like to hand over to the current team once again. Dr. Soumya.
Thank you, Dr. Neeraj, and thank you, Dr. Sanjukta. I think we look forward to circulating and keep up this allergy bulletin. Can I call upon Dr. Mitesh to conclude the session?
So once again, thank you, past chairperson, present chairperson, secretary, and special thanks to Dr. Krishnamon sir. As usual, you are an excellent moderator, sir. And thanks to all the panelists, Dr. Gopi, Dr. Jijo, Dr. Asha. So they have mentioned everything about GINA guideline, how to diagnose, step up, step down, role of ICS, doses of ICS. Excellent session, and all the best for the new team. And I would like to request all of you to register for the Meet Ped Allercon, which is going to be held at Agra, 8th and 9th May. The registration is still open for early bird, so please register and try to come. Thank you everyone. Dr. Sanjukta madam, thank you so much for excellent bulletin presentation. So good night everyone. Krishnamon sir, madam.
Thank you.
Good night. Thank
Good
you.
night, all.
Good night.
Good night, sir. Neeraj Gupta sir. Good night.
everyone.
Thank you.
Thank you.